You're listening to the Smart Policy Podcast, a production of the University of Tennessee's Institute for Public Service. According to the most recent report from the Tennessee Department of Health, 2/3 of all overdose fatalities are male, most of whom are aged 25 to 54. And according to independent research, this group is also far more likely to lack health insurance.
If you are a 24-year-old male, you have almost zero potential of getting insurance through TennCare. It's really challenging. And when you look at the statistics, the 24-year-old male is a large portion of the substance use disorder population, especially in rural Tennessee.
My guest this month is Bob Merritt, CEO of Myrtle Recovery Centers in rural Scott County. Drawing on a long career in behavioral health care, Mr. Merritt has seen firsthand how the kind of health insurance you have can significantly impact the quality of care that's even available to you.
It's surprising on how many places don't want this type of insurance and that type of insurance. And there's a couple reasons. Not everyone wants to accept TennCare. As I said, it's a lower reimbursement rate.
And that's if you have health insurance at all, which about 10% of the Tennessee population does not. In this conversation, we explore why it is that the people most at risk of dying of an overdose have the hardest time getting health insurance, and why that ends up costing the taxpayer. Addiction is certainly a chronic illness, but at the same time, it isn't quite exactly like diabetes or high blood pressure. And this important distinction has significant implications for the healthcare system.
Some taxpayer or some facility is going to be on the hook for that $500,000 worth of health care. Being able to provide treatment for those uninsured people would make a substantial difference, because any chronic illness without treatment only gets worse. Hello, I'm Bob Merritt. I am the Chief Executive Officer of Myrtle Recovery Centers Incorporated, located in Oneida, Tennessee. I have focused my career on behavioral health starting, 35 years ago.
Oh, wow.
Was a psych tech in Johnson City a long time ago, and just grew from there. But no, I have addiction and behavioral health illnesses go pretty much hand in hand. There's a lot of comorbidities, a lot of co-intermingling. I remember the times when, at one time you had to be treated for your behavioral health problem before we could treat your addiction, vice versa. We had to treat your addiction before we could treat your behavioral health problem. And then, someone came with the radical idea of, hey, let's do everything together.
Yeah, there might be a connection here. How about
Exactly. We haven't really truthfully accepted as a society that there is a biological connection to addiction. We still believe it's, there's a lot of choice there. And granted, there could be some choice to begin with, but eventually, the same way that your brain tells you have to eat, once you become addicted, is the same way your brain tells you must find that substance.
Yeah, that's an excellent way of putting it. So you now operate a treatment center in a rural area.
Yes.
What are the biggest things, and what are the biggest differences, would you say?
I think for the reason we wanted to put it up there is that we believe in rural healthcare first and foremost. Mm-hmm. It's important because rural communities have always been underserved. I mean, it's just what it is. We wanted to put a treatment center in a portion of the unused critical access hospital that's up there, because we believe wholeheartedly that the critical access hospital is the hub of the community healthcare. So being able to come to a central location to be able to get your physical care needs met, along with your, substance use disorder. And what we also do there at Myrtle is we also look at the behavioral health aspects as well. We're not going to be able to only treat the behavioral health piece. There needs to be a addiction component with that, or a substance use disorder component. But we understand how they intertwine. So we work with that. What we also see, and one of the reasons is that it's challenging enough for someone who has an addiction to get to decide to go to treatment. Once they decide to go to treatment, if they have to drive an hour and a half to get to the available treatment center, that may work for them, but how often are they going to get any visits? How often are they going to get any support from their family who are it's already tenuous at best in general, most cases, so now you're going to ask your mom and dad or whoever to drive you, 2 hours to a treatment center and then come and see you where they have to drive 2 hours down and 2 hours back for a 30-minute visit. Mm-hmm. It's pretty challenging. So other challenges we have seen, of course, we are in a rural area. So we have a smaller catchment area. In other words, if we were located in downtown Knoxville, there's a lot more folks than available that need assistance than there are in downtown Oneida.
Just a larger patient population.
Exactly.
Okay, gotcha. Now, you mentioned the critical access hospital.
Yes.
For the average person who's not, like a healthcare policy wonk, what's the difference between that and just a hospital?
A critical access hospital is a designation from the federal government that allows hospitals to operate in a smaller, much more condensed version than what we see like at UT Medical Center. That's a 600-bed quaternary care facility that takes care of everything. Critical access hospital, the idea is that it's close to your community. You're hopefully within 10 minutes, 20 minutes away from the hospital. We have a fully functioning emergency room. You come in, you can get stabilized, but it allows you to get that first assist as quickly as possible. In other words, there again, if the critical access hospitals weren't where they are, your first access to healthcare could be 2 hours away.
Okay, so we have distance, we have transportation issues related to that, we have all sorts of accessibility problems. Even the idea of a critical access hospital implies that you have to have a different financial model. What role is health insurance playing?
So we took the TennCare rates, okay, and we built the pro forma based upon TennCare rates because TennCare doesn't reimburse as much as a lot of the other private insurances and a lot of other insurances and a lot of other Medicaid in other states. So TennCare is a lower rate. So we built everything based upon that. That way we would know what we could staff, how many beds we would need to quote unquote break even, and what we needed to do from a marketing standpoint to be able to get those kind of folks in to be able to make sure we can sustain our operations.
How important is the TennCare population to your services or just recovery services in general?
I think that it's incredibly important because not everyone wants to accept TennCare, okay? As I said, it's a lower reimbursement rate. What we wanted to set up was in this rural healthcare consortium, more or less, is we wanted to be able to provide for those patients who do have TennCare. We wanted to be able to provide for those patients who are disadvantaged. And oftentimes that's what you see in very rural areas, and that's what you see in very rural areas with substance use disorder. When you look at the comparisons between substance use disorder in the rural America versus urban America, it's pretty staunch differences. I mean, it's statistically different in how many persons are affected in the rural versus how many are affected in the urban settings.
Right, and that's even factoring in things like underreporting.
Correct, exactly.
Yeah.
Because, you still live, when you're in rural America, and especially in rural Tennessee, there's a lot of things that go underreported in talking about substance use disorder especially. Substance use disorder, behavioral health illnesses.
Now, it's funny because we're talking only about 21% of the whole state's population.
Correct.
Has Medicaid, and a little bit less than that has Medicare. The vast majority of Tennesseans, you have the job-based, which is about 52%, and individual, like marketplace, that's like a 14%. Then, of course, there's also military and VA, but we're also dealing with a situation where 10% of Tennesseans don't have health insurance at all, and I'd imagine that the recovery population is very heavily represented in that.
They generally are, because we think about, when we look at someone that has substance use disorder, it generally doesn't start when you're much later in life. It generally starts when you're young. You start your experimentation, and whatever that substance is that releases that dopaminergic response is what you end up being quote unquote addicted to. Right. So as that starts at a young age, you aren't able to maintain employment like other folks might be. You're not able to keep your appointments like other folks and be able to navigate that system. And with TennCare itself, the way it's set up, if you are a 24-year-old male, you have almost zero potential of getting insurance through TennCare. Yeah. It's really challenging. And when you look at the statistics, the 24-year-old male is a large portion of the substance use disorder population, especially in rural Tennessee.
Yeah, I believe working age males are 2/3 of all fatal overdoses.
Exactly.
Yeah, just an enormous potential population base that isn't able to get coverage.
Exactly. And, I know that I've been in Tennessee. I've lived in Tennessee all my life, and I've been in healthcare for about 35, 40 years. And I have seen the wafts and wanes of, our system. And I remember when TennCare was first brought into Tennessee. Wonderful program, had tremendously wonderful intentions. Unfortunately, there was possibly a lack of oversight, and it ended up creating huge budget deficits for the state, huge issues.
Yeah, the early 2000s, the big issue of the day was TennCare reform just to keep it solvent.
Exactly. And they, disenrolled a lot of folks. And I understand why they had to disenroll some folks, but back then we didn't necessarily understand as well as we do today how much substance use disorder impacts the younger population. It not only affects the person, it affects the families, it affects so much in lost production. I mean, just tremendous amount. One of the things you see a lot of is, we work with some companies on remediation plans for their employees, simply because it's not as simple as, well, you've tested positive for drugs, we don't want you working for us anymore, because the working population is harder and harder to find. We go around everywhere and you see help wanted signs about everywhere, just about. Unemployment rate in Tennessee is not atrocious, but it's not as good as it could be.
No, it's above the national average. Yeah. The author Richard Reeves has talked about this recently, about how there are a lot of working age men that just aren't working at all.
Correct.
And it's like, what's going on? And of course, addiction is a large part of that. Substance use disorder is a large part of that, but there are a lot of factors going into this, of course. There has been a recent reform to TennCare. We're now in what is called TennCare 3. We're now on the block grant.
Exactly.
Has that, I know it's very recent, but has that changed anything?
I haven't seen it as much yet. However, we have had some folks come up who, because we always want, what we also do up there is I have case management department. And when people call that tell me they don't have insurance, we ask them to come up so we can help them apply for insurance. Of course, we'll always start with TennCare. We've had one recently that I really didn't expect to get accepted, did get accepted. However, they did have a tremendous chronic health history.
Okay.
It wasn't a whole lot. They weren't 24. They weren't young males. He was an older gentleman that had like I said, long chronic health history, and he was able to get approved through that. And I think that's probably some of the change. But I think that what we really have to do is to look at how we could expand that, because if we accept that substance use disorder is a disease, which everyone broadly accepts it as an illness, as a chronic illness, we have to start thinking about ways that we can help fund that. Now, granted, there's a lot of dollars floating around from some of the opioid settlements. That's going to a certain amount of folks, and that's good. That's really helpful. But the biggest concern is that not everybody would qualify to be able to get those funds. And how we use those funds can be a little different from area to area. in the rural area, if we took those funds and focused on prevention, that's quite beneficial. But I don't know how it would be beneficial for those folks who are already entrenched in the illness. You know?
Right.
So being able to provide treatment for those uninsured people would make a substantial difference, because any chronic illness without treatment only gets worse. That's simple. You can't talk yourself out of being a diabetic. You can't talk yourself out of having hypertension. You can't talk yourself out of being depressed, chronically depressed. And it's hard to talk yourself out of being having a substance use disorder. It's surprising on how many places don't want this type of insurance and that type of insurance. And there's a couple reasons. One, the reimbursement's low, or the amount of quote-unquote hoops you have to jump through to be able to get paid is high. So it's just easier to deal with the straight commercial Blue Cross Blue Shield, because you submit a bill, they submit you money.
Right.
And,
It's a strong
it's simple.
competition.
Yeah, it's just simple. But no, I think that as we continue to look at this and as we research it and as we focus on harm reduction, because that's where the true cost of addiction comes into. Because these same folks who don't have insurance are the same folks who are getting into overdoses, the same folks who are going to the ED, the same folks who are going into the ICU intubated. It's not just always as simple as, well, they overdosed and they expired. Sometimes you don't expire, and you go through and use voluminous amounts of health care. And if you're uninsured, you're uninsured. It's not just for your substance use issue. You're uninsured for your ICU stay as well.
And that money's got to come from somewhere.
That money's got to come from somewhere.
That's where the premiums keep increasing for people who do pay for insurance.
Exactly. If you look at a recovery day at $500 a day, then you look at an intensive care unit day at $9,000 a day.
God.
So, there's a lot more recovery days you could pay for, and try not to get into that. Because when you explore that harm reduction model, I'll go back a little bit in my past. I did a study in Johnson City about the cost of homelessness, okay? We don't think about that because we oftentimes say, people choose to be homeless and we'll throw a little money at it here and there. But I had a guy that I followed. He was arrested, like 700 times.
My God.
In 2 years, okay? In 2 years, he was arrested 700 times. During this period, he went to the hospital, the emergency room, about 200 times, okay? He was admitted into the hospital about 5 times, okay, for long length of stay. But when you break down how much quote-unquote tax dollars are spent from the EMS service, from the police service, from community monies that went to fund various and sundry different items for him, it cost the city of Johnson City about $120 a day to keep him homeless.
Yeah. As opposed to if there had been some sort of stable housing,
right,
some connection to treatment,
exactly,
then all of those downstream costs would have been just completely avoided.
Exactly.
Right. Okay. So, like in recovery terms, if you pay for someone's treatment, you're not having to pay for, say, an endocarditis, which would require cardiovascular surgery.
Exactly. You want to try to address the problem at the least expensive point. And for me, and like I said, I've done this a long, long time, if you can address it early in the treatment model before they end up having that open heart surgery.
Right.
And before they end up, because once they get that open heart surgery, they may be more willing, they may not, because they may be feeling that, well, what do I have to lose? Yeah. But some taxpayer or some facility is going to be on the hook for that $500,000 worth of health care.
Yeah, all of us are, absolutely.
Yeah, exactly.
And you mentioned various ways the state's investing. I've seen things like the state our general budget, we've invested our 15% of the opioid settlement money into more naloxone, more treatment providers. I know we've used some of our block grant savings in 10 Care 3 to increase the pay and the number of mental health clinicians and addiction clinicians. This is good stuff for sure. I know we have Behavioral Health Safety Net.
Yes.
Does that cover a decent amount of services?
It does it's more truly for what I consider the severe and persistent mentally ill. Those who may not have been able to acquire their TennCare or their other insurances yet. They may not have been able to go through the disability process. Because when you see those folks with that severe and persistent mental illness, they have their own set of challenges. Because, you're asking someone who has the inability to process sometimes to be at point A at this time. And if you're not at point A at this time, you don't get services anymore.
The organ making decisions is the organ that has the disease.
Exactly.
Right. Yeah.
Exactly. So similar with, like I said, we talked about a little bit on substance use, sometimes it's very difficult for those folks to stay in recovery long enough to go through that process to get what they need in order so they could get insurance, so they could get treatment. Because as they're going through these things, they're just like the rest of us as we go through any bureaucracy, we're faced with challenges and hurdles we have to overcome. When you have a brain affected by mental illness or when you have a brain affected by substance use disorder, you're not able to, quote unquote, tolerate some of those hurdles as well as what you and I can. So it ends up being pushed back. I'll go back to being the homeless situation. No one wakes up in the morning and says, I think I'll go live under a bush.
Right.
But you talk to a lot of folks after they've been living under that bush for a while, and they acclimate to that. And they give you the impression that they're happy doing it. And they may be because lifestyle is so much simpler. But it's also based upon how hard it is to, quote unquote, re-enter society.
Yeah, it might be survival.
Exactly.
Yeah, like we'll adapt to anything.
Exactly.
Yeah.
So it becomes that. It's challenging, and it's not the good thing I can say or the bad thing I can say. It's not just secondary to Tennessee. I've been in probably 20 different states doing different things in healthcare, and each state has their own issues. What you try to see. I remember when I first went to California, I'd heard so much about the California mental health system, and I was so anxious to see how it worked. And then when I got there, I realized that maybe not so much. Yeah. So
Right. You mentioned Medicaid expansion.
Yes, sir.
Earlier. I'd just like your thoughts on that.
I think that it is to be able to truly address what we're facing right now. I think it's imperative that we do that, because without Medicaid expansion, we're still going to stay in this harm reduction model that really doesn't reduce a lot of harm. And I hate to say it that way, because we do a tremendous amount. I know a lot of folks who do a tremendously wonderful job on prevention. I know a lot of folks who do a tremendously wonderful job on being able to get naloxone out.
But they're saving lives for sure.
No, without a doubt, tremendous amount. But I think that until we have the ability for folks to get into treatment, and actually high quality treatment where they can, come out on the other end for at least, 6, 8, 10 months or forever in recovery, it's a never ending circle. Because I know people that I've talked to up at Myrtle who have overdosed 3 times in a week. Lord. Now, thankfully, they did have the naloxone, and they were able to. Only one of them had to go to the hospital.
So they stayed alive.
They stayed alive, right. But just as easy as they were able to get the naloxone and maintain their breathing and stay alive, they could have easily passed.
Right.
And that's still like I said, until we can address the treatment component, it's challenging. I know there's a lot of good folks, like I said, who do the prevention and do a great job in prevention. I know that I work closely with an organization up in Oneida that does a tremendous job working with the high schools and middle schools. Stand, yes.
Yeah, excellent group.
Does a tremendous job. But unfortunately, they are limited once that prevention fails, if it does fail. The problem is they were missing a piece. They couldn't get the treatment area, when you need your inpatient treatment. So they would call and try to find a state-funded bed or find someone who would take TennCare, and they kept hearing no. But I think with the expansion, if we were able to expand Medicaid and get folks like this some services, I do think it makes a difference. I believe wholeheartedly it would make a difference. We know we've accepted the cost of diabetes. When we look at that, there's study after study after study that says, untreated diabetes does this, this, and this, and it costs the healthcare system an unbelievable amount of money, We focus on that, and we try to help people, invent different things to make sure that they can monitor their blood sugars more frequently and more accurately. But similar situation, with the substance use disorder, very similar mechanism of action in a way, but we just think that they need to pick themselves up by their bootstraps, and if they wanted to quit, they could. Like we go back to what I've said a couple times, because it's so, the same system that makes you hungry is the same system that wants you to use those substances, except it's much more powerful.
So we need all of it. We need prevention to stop people from ever using it. We need harm reduction to keep those who are in active addiction to stay alive. But we can't forget treatment. We need to do more to expand access to treatment, is what you're saying.
I think that access to treatment plays a vital role, because, in a perfect world, we would wave our magic wand and nobody would ever start using.
Right.
That would be, where we would want to end up. I don't know that would ever happen. It would be wonderful that everybody that used had an automatic naloxone distributor system that they carried around with them. As soon as it felt their respirations go down, it would administer. I don't know that we can get there.
I think that'd be probably pretty expensive, too.
Yeah. So when we look at these things, the component that we're not able to do as well as we could is the treatment, because it's a little bit more expensive. It's a little bit more intense. It requires both a commitment from the facility and the patient to see the commitment of some of the folks we've had, just that are so happy that they don't have to go to Knoxville. And after they're able to get visitors, to see their parents or their significant other come in and just see them in so much better place than they've seen them before. It's incredibly rewarding to see that, to know that there is some impact being made, and this is how we make that impact. You provide that high quality treatment in an accessible area for an accessible fee. A lot of places don't like the marketplace plans because there's usually a very high deductible, and there's usually, quote unquote, lots of hoops to jump through.
Right.
We wanted to be able to take those, so we worked through those with all the insurance agencies. We wanted to accept TennCare because, like I said, we wanted to put very high quality treatment that can be accessible by folks from the marketplace, by TennCare, because every single human deserves the same opportunities. You can't choose the path that everybody takes, but everybody should be able to choose which path they want to go down. And when you put someone in that box that you can only go to here and here and here because that's the only place that'll accept your insurance, then it challenges them, because there are still some quote-unquote do-it-yourself detoxes and residential programs out in the world. You go in and, we all talk about what we can do better and how we can do better. Not all of them are as structured as others. I like to consider ours very structured. I like to consider ours, like I said, we're trauma focused. I like to think that we're trying to get to the root of the problem. And that's all we want to do, is to help people move forward.
Bob, thank you very much for joining me. I think this was a really productive conversation.
Well, good, great. It was my honor. I appreciate the opportunity. And, like I said, I appreciate it very much to get to talk about some of the things that are important to me and important to Myrtle.
For more episodes on in-depth discussions on Tennessee policies related to substance use disorder by a range of local experts, please subscribe to us wherever you get podcasts and visit our website at smart.tennessee.edu. I'm Jeremy Corvelis. Thank you for listening, and see you next month.